This is a short presentation on arterial blood gases intended for students starting placement at Leeds Teaching Hospital. Arterial blood gases is a test that provides a precise measurement of the oxygen and carbon dioxide levels in your body. It can help determine how well your lungs and kidneys are working. It's taken via either an arterial stab or an arterial line. When looking at arterial blood gases, you want to look at the pH, which is the indicator of the amount of hydrogen ions in the blood, and it looks at whether the blood is acidic or alkalytic. You also look at your PCO2, which is the partial pressure of carbon dioxide, and this is the measure of pressure of carbon dioxide dissolved in the blood. It determines how well the carbon dioxide is able to flow out of the body. It's an acidic component and is an indicator of respiratory function. You've got your PO2, which is your partial pressure of oxygen, which is a measure of the pressure of oxygen dissolved in the blood. It determines how well oxygen is able to flow from the lungs into the blood. You've got your HCO3, which is your bicarbonate, which is a chemical that helps prevent the pH of the blood from becoming too acidic or too alkalytic, and it's an indicator of metabolic function. You've got your base excess, which is the quantity of strong acid or alkaline that is required to restore the pH to normal. Why? So when looking at your blood gases, you want to look at the acid-base balance, your oxygenation and your ventilation, and the blood gases can help show these things as well. Normal values of arterial blood gases can be seen on the slide. If your pH is below 7.35, you're acidotic. If you're above 7.45, you're alkalotic. And it's always important to make sure that you check that the patient's details are correct. The time it was taken, the date it was taken, and especially the oxygenation the patient was on at the time the arterial blood gas was taken. When you're looking at blood gases, you want to look at their pH. Are they acidotic or are they alkalotic? You want to look at their CO2 and you want to look at their bicarb and their base excess. When you're looking at arterial blood gases, it can show whether they're in type 1 or type 2 respiratory failure. Type 1 respiratory failure is a disturbance of the VQ matching, which leads to a decrease in PO2, so they're hypoxic. However, their PCO2 remains normal or decreased. The causes of type 1 respiratory failure are included on the slide. They include COPD, pulmonary fibrosis, pulmonary embolisms, bronchiectasis, obesity, amongst others. Type 2 respiratory failure is due to poor or under ventilation, which leads to an increase in carbon dioxide and a decrease in oxygenation, so your PO2. Your causes of your type 2 respiratory failure are included on the slide below. They include your COPD, your myasthenia gravis, your polyneuropathies, your primary muscle disorders, your head and cervical cord injuries, your ARDS patients, your obesity hyperventilation syndrome as well. So when looking at arterial blood gases, you want to look at the acid-base disturbance. This reflects the acid-base balance and responds to the metabolic and respiratory changes within the body. Body cells and chemical reactions are acutely sensitive to the pH of their environment. So the lower the pH, they're acidic. The higher the pH, they're alkaline or alkalotic. If the acid-base balance is disturbed, for example, if the CO2 removal by the lungs is abnormal, the production of acid from tissues is abnormal and the removal of acid is abnormal. And this can be shown by changes in the CO2, which is classed as a respiratory acid-base disturbance, or changes in the bicarb, which is a metabolic acid-base disturbance. So respiratory acidosis can be split into acute and chronic. So when it's acutely, there's a reduction in alveolar ventilation, which causes an increase in the carbon dioxide. The pH falls to become acidic, but there's not enough time for renal correction, which is why the bicarb stays normal. This is generally what happens when there's a sudden reduction in ventilation, such as an obstructive airway or an acute neurological damage. Your chronic respiratory acidosis is generally when if there's underventilation for whatever reason is sustained for a few days. So this means that the pH becomes normal. You've got a higher level of CO2 in the body, and the reabsorption of bicarb will correct the acidosis, which is why it's slightly higher and your pH is normal. And this tends to happen in sustained hyperventilation like COPD patients. Your respiratory alkalosis is usually acute. It's got an increase in pH and a decrease in carbon dioxide, but your bicarbonate is normal. And this is because the alveoli hyperventilation causes a fall in the CO2 and the corresponding rise in the pH. And it's generally seen in any form of acute hyperventilation. So your causes are your pulmonary embolisms, your acute severe asthma, your anxiety-related hyperventilation, high altitude, and symptoms can include dizziness, confusion, and a dry mouth. So metabolic acidosis is when there's a decrease in pH, a decrease in the CO2, and a decrease in the bicarb. And this is because there's an increase in acid, the carbon dioxide produced is removed by ventilation, and the net result is the lowering of the bicarb. So it's because the fall in pH causes the respiratory stimulation so that carbon dioxide is blown off. So respiratory compensation is inevitable when there's metabolic acidosis. And you can see that in renal disease, liver disease, prolonged lack of oxygen, shock, poisoning, and the symptoms are rapid breathing, confusion, and lethargy, so fatigue and tiredness. Metabolic alkalosis is when there's an increase in pH, a higher than normal or slightly elevated CO2, and an increase in bicarb. And this is because there's an increase in bicarb causes an increase in pH, which then the compensation is ventilation is reduced, and it occurs when there's an alkyl administration. So that's vomiting, reabsorption of bicarb hyperkalemia, large blood transfusion, and refeeding syndrome. And the symptoms include weakness and hyperventilation. So here's some examples of your blood gases. So looking at this slide, what can you tell me? We can see that they've got a pH 7.25, it's decreased, so they're acidotic. They've got a PCO2 of 7.3, elevated because it's above 6. We've got a PO2 of 10, which is low because it's below 11. Their bicarb is within range, their base excess is within range, and their SATs are 92. So what this is showing is an uncompensated respiratory acidosis with hypoxemia, or hypoxia, and it's an acute respiratory disorder. So here's example number 2. So looking at your screen, what can you see? So the pH is 7.52, which is slightly raised, so it's going to the alkaline trend. Your CO2 is below 4.7, so it's decreased. Your PO2 is within range, your bicarb's within range, your base X is hiring up to that alkaline, and your SATs are fine of 97. So what you're seeing here is you've got an uncompensated respiratory alkalosis, and that a cause of this could be due to the fact they're hyperventilating. Example number 3 is you've got your pH of 7.18, which is acidotic, your PCO2 of 6, which is in range, your PO2 of 13.8, which is in range, your bicarb of 18, which is low. You've got your base excess of +2 and your SATs of 95. So what you're seeing here is an uncompensated metabolic acidosis, and it's probably on an acute disorder such as DKA. Example number 4 is you've got a raised pH, you have got a raised CO2, you have got a PO2 within range, you've got a raised bicarb and a raised base excess, and what you're seeing here is a metabolic alkalosis with a respiratory compensatory of CO2.